Acute kidney injury, or AKI, is the term used to encompass the entire scope of the syndrome, ranging from a slight deterioration in kidney function to severe impairment. AKI is characterized by a rapid loss of kidney function. This loss is accompanied by a rise in serum creatinine and or a reduction in urine output. The severity of the dysfunction can range from a small increase in serum creatinine or reduction of urine output to the development of azotemia, which is an accumulation of nitrogenous waste products such as urea, nitrogen, and creatinine in the blood. AKI can develop over hours or days with progressive elevations of the blood urea nitrogen, or the BUN, creatinine, and potassium, with or without a reduction of urine output. Although AKI is potentially reversible, it has a high mortality rate. AKI usually affects people with other life-threatening conditions. Most commonly, AKI follows severe prolonged hypotension or hypovolemia or exposure to a nephrotoxic agent. Hospitalized patients develop AKI at a high rate, 1 in 5, and have a high mortality rate. When AKI develops in patients in intensive care units, the mortality rate can be as high as 70 to 80%. The causes of AKI, which are multiple and complex, are categorized as prerenal, interrenal or intrinsic, and postrenal causes. It's important to distinguish prerenal oliguria from oliguria of interrenal AKI. In prerenal oliguria, there is no damage to the kidney tissue or the parenchyma. The oliguria is caused by a decrease in circulating blood volume, like severe dehydration or in heart failure or anything that involves decreased cardiac output. It is reliably reversible with appropriate treatment. With a decrease in circulating blood volume, autoregulatory mechanisms that increase angiotensin II, aldosterone, norepinephrine, and antidiuretic hormone attempt to preserve blood flow to the essential organs. Prerenal azotemia results in a reduction in the excretion of sodium, less than 20 milliequivalents per liter, increased salt and water retention, and decreased urinary output. Prerenal conditions contribute to interrenal disease if renal ischemia is prolonged. If decreased perfusion persists over an extended time, the kidneys lose their ability to compensate and damage to the kidney parenchyma occurs. Interrenal causes of AKI include conditions that cause direct damage to the kidney tissue, resulting in impaired nephron function. The damage from interrenal causes usually results from prolonged ischemia, nephrotoxins, hemoglobin released from hemolyzed red cells, or myoglobin released from necrotic muscle cells. Nephrotoxins can cause obstruction of the interrenal structures by crystallization or by causing damage to the epithelial cells of the tubules. Hemoglobin and myoglobin can block the tubules and cause renal vasoconstriction. Diseases of the kidneys, such as acute glomerulonephritis and systemic lupus erythematosus, may also cause AKI. This is an image of a cross-section of tissue damaged by glomerulonephritis. Glomerulonephritis is primarily a renal disease. Glomerular injury is a result of inflammation, and that can be caused by a streptococcal infection, systemic lupus erythematosus, or systemic sclerosis, better known as scleroderma. Acute tubular necrosis, or ATN, is the most common interrenal cause of AKI and is primarily the result of ischemia, nephrotoxins, or sepsis. Ischemic or nephrotoxic ATN are responsible for 90% of interrenal AKI cases. Severe kidney ischemia causes a disruption in the basement membrane and patchy destruction of the tubular epithelium. Nephrotoxic agents cause necrosis of tubular epithelial cells, which slough off and plug the tubules. ATN is potentially reversible if the basement membrane is not destroyed and the tubular epithelium regenerates. ATN is the most common cause of AKI for hospitalized patients. Risks associated with development of ATN while in the hospital include major surgery, shock, sepsis, blood transfusion reaction, muscle injury from trauma, prolonged hypotension, and nephrotoxic agents. This is an image of a cross-section of tissue with acute pyelonephritis. It's usually caused by a bacterial infection of the renal parenchyma. It can be caused by ascending bacteria from a lower urinary tract infection. The symptoms are chills, high fever, vomiting, malaise, flank pain, urgency, frequency, and dysuria. Patients may also present with costovertebral tenderness on the affected side. So we've talked about prerenal and intrarenal. Now let's talk about postrenal causes of AKI. They usually involve mechanical obstruction of outflow of urine. As the flow of urine is obstructed, urine refluxes into the renal pelvis, impairing kidney function. The most common postrenal causes are a benign prostatic hyperplasia, prostate cancer, calculi, trauma, and extrarenal tumors. Bilateral ureteral obstruction leads to hydronephros, which is kidney dilation, increase in hydrostatic pressure, and tubular blockage, resulting in progressive decline of kidney function. If bilateral obstruction is relieved within 48 hours of onset, complete recovery is likely. Prolonged obstruction can lead to tubular atrophy and irreversible kidney fibrosis. Postrenal causes of AKI account for less than 10% of AKI cases. Prerenal and postrenal AKI that has not caused intrarenal damage usually resolves quickly with treatment. When parenchymal damage occurs due to either prerenal or postrenal causes, or when parenchymal damage occurs directly as with intrarenal causes, AKI has a prolonged course. Clinically, AKI may progress through phases: oliguric, diuretic, and recovery. When a patient does not recover from AKI, then chronic kidney disease or CKD may develop. The Rifle classification is used to describe the stages of AKI. R stands for risk, and that's the first stage of AKI, which is followed by I for injury. It's the second stage. Then AKI increases in severity to the final or third stage, which is F, failure. The last two letters stand for the two outcome variables, which are L, loss, or finally E, end-stage renal disease. As we begin to talk about the clinical manifestations of acute kidney injury, let's begin with urinary changes. The most common initial manifestation of AKI is oliguria, and that's a reduction of urine output less than 400 ml per day. Oliguria usually occurs within 1 to 7 days of the injury to the kidneys. If the cause is ischemia, oliguria often occurs within 24 hours. The oliguric phase lasts on average from 10 to 14 days, but can last months in some cases. The longer the oliguric phase lasts, the poorer the prognosis for complete recovery of the kidney function. About 50% of patients will not be oliguric, making the initial diagnosis more difficult. Changes in urinary output generally do not correspond to changes in glomerular filtration rates. However, changes in urine output are often helpful in differentiating the etiology of the AKI. For example, anuria, which means no urine output, is usually seen with urinary tract obstructions. Oliguria is commonly seen with prerenal causes, and non-oliguric AKI is seen with acute interstitial nephritis and ATN. A urinalysis may show CAS, RBCs, or WBCs, white blood cells. The CAS are formed from mucoprotein impressions of the necrotic renal tubular epithelial cells, which detach or slough into the tubules. Urine-specific gravity, measures of the concentration of solutes in the urine, is normally 1.003 to 1.030. Urine osmolarity is used to measure the number of dissolved particles in the urine. Urine osmolarity range is 300 to 1300 milliosmoles per kilogram. As a measure of urine concentration, it is more accurate than the specific gravity. Hypovolemia, or volume depletion, has the potential to exacerbate all forms of AKI. Fluid replacement is often sufficient to treat many forms of AKI, especially the prerenal causes. The other side of that coin is that when urine output decreases, fluid retention occurs. The severity of the manifestations depend on the extent of the fluid overload. In the case of reduced urine output, anuria or oliguria, the neck veins become distended with bounding pulses. Edema and hypertension may develop. Fluid overload can eventually lead to heart failure, pulmonary edema, and pericardial and pleural effusions. In the normal kidney, excess hydrogen ions are excreted to maintain a physiologic balance of the blood pH. The impaired kidneys cannot excrete hydrogen ions or the acid products of metabolism. Serum bicarbonate production is decreased because of defective reabsorption and regeneration of bicarbonate ions. Serum bicarbonate is depleted through buffering of acidic hydrogen ions and metabolic end products. The patient with severe acidosis may develop Kussmaul respirations, which are rapid, deep respirations in an effort to compensate by increasing the exhalation of carbon dioxide. In the oliguric phase of AKI, we also may have hematological disorders. Remember, hospital-acquired AKI often occurs in patients who have multiple organ failure. Leukocytosis is often present with AKI. The most common cause of death in AKI is infection. The most common site of infection are the urinary and respiratory systems. We will also see waste product accumulation. The kidneys are the primary excretory organs for urea, which is an end product of protein metabolism, and creatinine, which is an end product of endogenous muscle metabolism. Elevated BUN levels can also be caused by dehydration, corticosteroids, or catabolism resulting from infections, fever, severe injury, or GI bleeding. The best serum indicator of AKI is creatinine because it's not significantly altered by other factors. Our patient may also have neurological disorders. Neurological changes can occur as nitrogenous waste products accumulate in the brain and other nervous tissue. The manifestations can be as mild as fatigue and difficulty concentrating, and then escalate to seizures, stupor, and coma. So now let's talk about the two phases of the acute kidney injury. The first is the diuretic phase. During the diuretic phase of AKI, daily urine output usually is around 1 to 3 liters, but may reach 5 liters or more. The high urine volume is caused by osmotic diuresis from the high urea concentration in the glomerular filtrate and the inability of the tubules to concentrate the urine. In this phase, the kidneys have recovered their ability to excrete wastes, but not to concentrate urine. Large losses of fluid and electrolytes require the patient to be monitored for hyponatremia, hypokalemia, and dehydration. The diuretic phase may last 1 to 3 weeks. Near the end of this phase, the patient's acid-base, electrolyte, and waste product, BUN and creatinine values, stabilize. Next is the recovery phase. The recovery phase begins when the glomerular filtration rate increases, allowing the BUN and serum creatinine levels to decrease. Major improvements occur in the first 1 to 2 weeks of this phase, but kidney function may take up to 12 months to stabilize. The outcome of AKI is influenced by the patient's overall health, severity of kidney failure, the number of types of complications. Some individuals do not recover and progress to end-stage renal disease. The older adult is less likely to have complete recovery of kidney function. Patients who recover may achieve clinically normal kidney function but remain in the early stages of chronic kidney disease. Diagnosis of AKI begins with a thorough history. That is essential to diagnose the etiology of the AKI. We want to consider pre-renal causes when there's a history of dehydration or blood loss. We suspect intrarenal causes if the patient's been exposed to potentially nephrotoxic drugs or contrast media used in radiologic studies. Post-renal causes are suggested by a history of changes in the urinary stream, stones, benign prostate hyperplasia, or bladder or prostate cancer. An increase in serum creatinine may not be evident until there's a loss of more than 50% of kidney function. The rate of increase in serum creatinine is also important as a diagnostic indicator in determining the severity of the injury. Urinalysis is an important diagnostic test. Urine sediment containing abundant cells, casts, or proteins suggest intrarenal disorders. The urine osmolarity, sodium content, and specific gravity help in differentiating the causes of AKI. Urine sediment may be normal in both prerenal and postrenal AKI. In intrarenal problems, hematuria, pyuria, and crystals may be seen. Kidney ultrasonography is often the first test done since it provides imaging without exposure to potentially nephrotoxic contrast agents. It is useful for evaluating for possible kidney disease and obstruction of the urinary collection system. A renal scan can assess abnormalities of the kidney blood flow, tubular function, and the collection system. A CT scan can identify lesions, masses, obstructions, and vascular abnormalities. Renal biopsy is considered the best method to confirm intrarenal causes of AKI. Sometimes, to establish the diagnosis of AKI, other testing might be required. There's a great table in your book, 46-4, that gives you the diagnostic tests. Some studies are contraindicated in patients with kidney disease. Obtaining an MRI or a magnetic resonance angiography (MRA) study with the contrast media gadolinium is not advised in patients with kidney failure. The administration of gadolinium can be potentially fatal. In patients with kidney failure, contrast-induced nephropathy, or CIN, can occur with contrast media for diagnostic studies causing nephrotoxic injury. In patients with diabetes receiving metformin, the drug should be held for 48 hours prior to and after the use of contrast media to decrease the risk of lactic acidosis. The best way to avoid CIN is to avoid exposure to contrast media by using other diagnostic tests such as ultrasound. So now we move on to care. Because AKI is potentially reversible, the primary goal of treatment is to eliminate the cause, manage the signs and symptoms, and prevent complications while the kidneys recover. The first step is to determine if there is adequate intravascular volume and cardiac output to ensure adequate perfusion of the kidneys. Diuretic therapy may be administered and usually includes loop diuretics such as furosemide, which is Lasix, or Bumex, or an osmotic diuretic such as mannitol. If AKI is already established, forcing fluids and diuretics will not be effective and may be harmful. Closely monitor fluid intake during the oliguric phase of AKI. Hyperkalemia is one of the most serious complications of AKI because it causes life-threatening cardiac dysrhythmias. Both insulin and sodium bicarbonate serve as temporary measures for treatment of hyperkalemia by promoting a shift of potassium into the cells, but potassium will eventually be released. Calcium gluconate raises the threshold at which dysrhythmias will occur, serving to temporarily stabilize the myocardium. Only sodium polystyrene sulfonate, or kxalate, and dialysis actually remove potassium from the body. Never give this drug to a patient with a paralytic ileus because bowel necrosis can occur. Conservative therapy may be all that is necessary until kidney function improves. If conservative therapy is not effective in treating AKI, then renal replacement therapy, or RRT, is used. Controversy exists about the timing of RRT and AKI. The most common indications for RRT and AKI are 1. Volume overload resulting in compromise of cardiac and or pulmonary status. 2. Elevated serum potassium levels. 3. Metabolic acidosis, serum bicarbonate levels less than 15 milliequivalents per liter. 4. A BUN level greater than 120 milligrams per deciliter. 5. Significant change in mental status. And 6. Pericarditis, pericardial infusion, or cardiac tamponade. Although lab values provide rough parameters, the best guideline is the clinical status of the patient. There is no consensus regarding the best approach to renal replacement therapy. Even though peritoneal dialysis is considered a viable option for RRT, it's not frequently used. Intermittent hemodialysis, those are those intervals of 4 hours, either daily or every other day, up to 3 to 4 times per week, is the method of choice when rapid changes are required in a short period of time. Continuous renal replacement therapy, or CRRT, has been used effectively and involves cannulation of an artery and a vein. CRRT is provided continuously over approximately 24 hours through the cannulation of a vein or a catheter placement. CRRT has much slower blood flow rates compared to intermittent HD or hemodialysis. Hemodialysis is the method of choice when changes are required emergently. It is technically more complicated because specialized staff and equipment and vascular access are required. It also requires anticoagulation therapy to prevent the patient's blood from clotting when the blood makes contact with the extracorporeal dialysis circuit. Rapid fluid shifts during hemodialysis may cause hypotension. The goal of nutritional management in AKI is to provide adequate calories to prevent catabolism despite restrictions that prevent electrolyte and fluid disorders and azotemia. Nutrition intake must maintain adequate caloric intake, which is about 30 to 35 calories per kilo, and zero point 0.8 to 1.8 grams of protein per kilogram of desired body weight. This is to prevent the breakdown of body protein. Adequate energy should primarily be from carbohydrate and fat sources to prevent ketosis from endogenous fat breakdown and glucogenesis from muscle protein breakdown. Essential amino acids may be supplemented. Potassium and sodium are regulated in accordance with plasma levels. Sodium is restricted as needed to prevent edema, hypertension, and heart failure. Dietary fat intake is increased so that the patient receives at least 30% to 40% of total calories from fat. If the patient cannot maintain adequate oral intake, enteral nutrition is the preferred route for nutritional support. Nursing care includes monitoring vital signs, weight, and fluid intake and output. Daily monitoring of the patient's urine output is essential because this information provides prognostic implications and is crucial in determining therapy and daily fluid volume replacement. Examine the urine for color, specific gravity, glucose, protein, blood, and sediment. Assess the patient's general appearance, including their skin color, edema, neck vein distension, and bruises. If a patient is receiving dialysis, observe the access site for signs of inflammation and exudate. Evaluate the patient's mental status and level of consciousness. Examine the oral mucosa for dryness and inflammation. Auscultate the lungs for crackles and wheezes or diminished breath sounds. Monitor the heart for an S3 gallop, murmurs, or a pericardial friction rub. Assess EKG readings for dysrhythmia. Review lab values and diagnostic test results. All of the previous data are essential for developing an interprofessional plan of care. Your nursing diagnoses include fluid volume excess, risk for infection, fatigue, anxiety. Planning the overall goal of the patient with AKI will be 1. Complete recovery without loss of kidney function. 2. Maintain normal fluid and electrolyte balance. 3. Have decreased anxiety. And 4. Adhere and understand the need for careful follow-up care. Prevention and early recognition of AKI are the most important components of care. Prevention is directed primarily toward identifying and monitoring high-risk populations, controlling exposure to nephrotoxic drugs and industrial chemicals, and preventing prolonged episodes of hypotension and hypovolemia. In the hospital, the factors that increase the risk for developing AKI are pre-existing chronic kidney disease, older age, massive trauma, major surgical procedures, extensive burns, cardiac failure, sepsis, or obstetric complications. Careful monitoring of the patient's weight, intake and output, and fluid and electrolyte balance are essential. Assess and record extrarenal losses of fluid from vomiting, diarrhea, hemorrhage, and increased insensible losses. Prompt replacement of significant fluid losses help prevent ischemic tubular damage associated with trauma, burns, and extensive surgery. Intake and output records and the patient's weight provide valuable indicators of fluid volume status. Aggressive diuretic therapy for the patient with fluid overload from any cause can lead to a reduction in renal blood flow. Monitor kidney function in individuals who are taking drugs that are potentially nephrotoxic. Nephrotoxic drugs should be used sparingly in the high-risk patient. When these drugs must be used, they should be given in the smallest effective doses for the shortest possible periods. Caution the patient about abuse of over-the-counter analgesics, especially non-steroidal anti-inflammatory drugs, as these may worsen kidney function in the patient with mild chronic kidney disease. Angiotensin-converting enzyme, or ACE inhibitors, can also decrease perfusion pressure and cause hyperkalemia. If other measures, such as diet modification, diuretics, and sodium bicarbonate, cannot control hyperkalemia, ACE inhibitors may have to be reduced or eliminated. However, ACE inhibitors are frequently used to prevent proteinuria and progression of kidney disease, especially in patients with diabetes. You have an important role in managing fluid and electrolyte balance during the oliguric and diuretic phases. Observe and record accurate intake and output. Measure daily weights with the same scale at the same time of each day to allow for evaluation and detection of excessive gains or losses of body fluid. 1 kilo is equivalent to 1,000 milliliters of fluid. Assess for the common signs and symptoms of hypervolemia in the oliguric phase or hypovolemia in the diuretic phase, potassium and sodium disturbances, and other electrolyte imbalances that may occur in AKI. Because infection is the leading cause of death in AKI, meticulous aseptic technique is crucial. If a patient with renal failure has an infection, it is important to recognize that the temperature may not always be elevated. Patients with kidney failure have a blunted febrile response to an infection. If antibiotics are used to treat an infection, the type, frequency, and dose must be carefully considered because the kidneys are the primary route of excretion for many antibiotics. As previously mentioned, nephrotoxic drugs should be used judiciously. Perform skincare and take measures to prevent pressure ulcers as mobility may be impaired. Mouth care is important to prevent stomatitis, which develops when ammonia, which is produced by bacterial breakdown of urea in the saliva, irritates the mucous membranes. Recovery from AKI is highly variable and depends on whether other body systems fail, the patient's general condition and age, and the length of the oliguric phase and the severity of the nephron damage. Protein and potassium intake should be regulated in accordance with kidney function. Regular evaluation of the kidney function through appropriate follow-up is necessary. Teach the patient the signs and symptoms of recurrent kidney disease. Emphasize measures to prevent the recurrence of AKI. The long-term convalescence period, 3 to 12 months, may cause psychological and financial hardship for the patient and the family. Make appropriate referrals for counseling. If the kidneys do not recover, the patient will need to transition to life on chronic dialysis or possible future transplantation. Although the causes of AKI in older adults are similar to younger adults, they are at increased risk for AKI. Dehydration is a predisposing factor and tends to occur much more frequently in older adults. Dehydration can occur from polypharmacy, the combinations of diuretics, laxatives, and drugs that suppress appetite or consciousness, acute febrile illnesses, and immobility from being bedridden. Other common causes of AKI in the older adult include hypotension, diuretic therapy, aminoglycoside therapy, obstructive disorders such as prostatic hyperplasia, surgery, infection, and contrast media. Mortality rates are similar for older and younger adults. Patients over 65 years of age are less likely to recover from AKI. Despite this, a patient's chronological age is not a barrier to offering renal replacement therapy.